This is Dr. Joseph Sarkissian. In this video, I will be performing a crestal sinus lift and placing a Z-Systems tissue-level, fully metal-free ceramic zirconia implant. The cone beam study with the simulated 5 by 10 millimeter implant reveals that I need not more than maybe 3 millimeters of sinus lift, which is totally acceptable for a crestal approach. I meticulously measure my depths. To be able to punch through the bone plate, I will need to stop 2 millimeters short of the sinus floor. If I go deeper, I may perforate. The D2 value measured here is measured from the top of the surgical guide to the osteotomy endpoint, which is carried out only with a pilot drill. After laying a conservative flap with the ultimate intent of displacing keratinized gingiva to the facial of the implant, I start the osteotomy through the guide and stop at the predetermined D2 depth, which I established with my cone beam study. I remove the guide and probe the base to make sure I have hard bone and have not perforated. After taking our first X-ray to confirm depth, I continue the osteotomy with the side-cutting special burrs from the Neobiotech crestal sinus lift kit. The stop is now set at the D1 depth. I proceed with a combination of bone stretching and burrs in sequence until I reach a diameter to allow a tight fit of the final bone punch. After my D1 depth is confirmed, I can use my zirconia burrs from the Z-Systems kit, which gives me the luxury of one depth stop for each burr. I take one more X-ray with a thicker pin provided in the Z-Systems kit and proceed to set the bone punch to a depth of D1 plus 2 millimeters. And of course, warn the patient about the hammering that he or she is about to experience. Once the bone plug is fractured, you feel the advancement of the punch and of course you slow down. After the bone plug is pushed up, I use the final diameter burr to match the implant size. Because we are using the tissue level implant, which has a wider tulip, I always like using the countersink drill for it, but in this case, since we are in maxillary bone, not to its full depth. To make sure we don't have a tear in the sinus membrane, we have the patient blow into the sinus while we pinch their nose. This is done a few times. If bubbles appear through the socket, that means the membrane has a tear. In our case, there were no bubbles, just blood welling up due to the pressure from the sinus membrane. A second method to test is to use a thick probe and gently push on the base of the socket, which will rebound like a trampoline, and a certain resistance will be felt. Now, earlier on, we had drawn a few vials of blood from the patient to be able to harvest some PRF, which we will be using for the sinus lift. After irrigating with ozonated saline, the PRF plugs are introduced into the socket and gently pushed up. This will allow the sinus membrane to separate from the sinus floor bone and lift up higher. And after inserting 2 to 3 PRF plugs, we are ready to insert the implant. The implant is torqued in at around 32 Newton centimeters. A PEEK screw is inserted to protect the implant. The conservative flap is sutured back, and the fact that this is a tissue level implant allows for the keratinized zone of the flap to rest on its buccal aspect. In the final X-ray, we notice the faint outline of the sinus membrane dome, which is, of course, hardly visible because PRF does not show up in X-rays. In a few months, however, the PRF will turn into bone. The patient is given postoperative instructions and told not to eat on that side for at least 2 months. And for good measure, we provide her with an Essex protective appliance to wear. Supplementation guidelines include at least 5,000 IUs of vitamin D daily, vitamin C, anti-inflammatory enzymes, and other sinus-related instructions. Thank you for watching.